everyone. Welcome to OsteoBites. We will give a few seconds for everyone to join and get settled in our virtual room today. I appreciate your taking time out of your day and spending it with us. Welcome everyone to OsteoBites. Thanks for joining us. My name is Christina Iptoma, and I'm mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Diana Azzam from Florida International University to discuss the clinical utility of functional precision medicine to guide treatments for osteosarcoma patients. Thank you so much, Dr. Azzam, for joining us on OsteoBites today. We are thrilled to have you, and we're also always excited to have our panelist, Andrew, joining us today. Everyone, please feel free to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Azzam. And before we get started, wanted to share a little bit more about our guest today. Dr. Diana Azzam is an assistant professor and research director of the Center for Advancing Personalized Cancer Treatments at Florida International University. She has a master's in biochemistry from the American University of Beirut, Lebanon, and a PhD in biochemistry and molecular biology from the University of Miami in Florida. Her lab focuses on implementing functional precision medicine approaches in adult and pediatric cancer patients that have run out of treatment options. Working with local hospitals, including Nicklaus Children's Hospital and Cleveland Clinic, Florida, her lab delivers individualized treatment plans based on a patient's cancer genomic profile and ex vivo drug response. She is currently engaged in 2 clinical studies to assess feasibility and clinical utility of functional precision medicine in relapsed refractory patients with childhood cancer and adult cancer. And I'll put those clinical trial links in the chat. Dr. Azzam is working on setting up the first CLIA-certified lab in the state of Florida dedicated for functional cancer drug testing. And her goal is to launch large-scale prospective multi-center randomized clinical trials to better assess the efficacy of functional precision medicine approaches in the treatment of refractory and relapsed cancers. And in parallel, she is working on utilizing functional precision medicine as a tool to reduce health disparities in childhood cancer patients for minority populations. She's also integrating a novel machine learning approach to identify specific biomarkers among minority populations that can be targeted using FDA-approved drugs. And her lab also investigates cancer stem cells and how they may result from chronic environmental exposures to toxic metals such as arsenic. Super exciting topics, and we're really excited for your presentation. Thanks so much for joining us today, Dr. Azzam. And I have just a few quick announcements before we get started. It's August, and that means we are officially in gold bow season. So each year for September Childhood Cancer Awareness Month, MIB Agents distributes beautiful gold bows to adorn mailboxes and front porches to create awareness. And bows are available for a suggested $25 donation. You can purchase one directly on our website, or you can also sign up to be a bow agent volunteer and sell and promote bow sales in your community. It's a really uplifting activity, and it's fun and it's easy, so we hope you join us. I'll put some links into the chat with some more info about that. I also wanted to share an open invitation to any researchers who are working on characterizing osteosarcoma with single-cell RNA sequencing and spatial transcriptomics to create an osteosarcoma atlas. We invite you to join the Osteosarcoma Single-Cell RNA-seq Working Group, which actually now has an official name. It's called CURE-OS, which stands for the Collaborative Understanding of the Range and Evolution of Osteosarcoma Single Cells. It's a working group dedicated to establishing standardized procedures for the collection, analysis, and dissemination of single-cell data in osteosarcoma. And there are 3 working group goals. The first is to disseminate knowledge through talks and collaborative review papers. The second is to develop and implement standardized experimental protocols and analysis methods. And then the third is to create a shared online repository for osteosarcoma single-cell research data. So if that is of interest to you and you're interested in participating, please email me at christina@mibagents.org. The group so far has been meeting about every 6 weeks or so. So I'll put some more info in the chat about that as well. And lastly, I did want to mention this just because I think this is really apropos for today's topic and presentation. There's a research opportunity that both the patient community and clinicians can participate in. CURE-ID is an initiative with the FDA and the NIH National Center for Advancing Translational Sciences, otherwise known as NCATS. It is both a website and a mobile app where healthcare providers, patients, and care partners can share their real-world treatment experiences with existing medications that are being used in a new way through a simple online case report form on their smartphone or computer. And so you can use CureID to basically kind of submit your treatment experience and any off-label drugs that you may have used for your disease. And by systemically collecting this real-world treatment experience, CureID can create a resource for the community to share information where no FDA-approved product that is proven to be safe and effective exists for the disease in question. So all these cases that are collected are made openly accessible, and I will put a link to more info in the chat where both clinicians and patient caregivers can submit an online case form, and then also see what data has been collected to date. It's just started, so I think right now there might be like 4 osteo cases in there. But I thought super on topic and interesting for today's presentation. Okay, that is it from me. Andrew, could you please introduce yourself?
Hi, my name is Andrew Basaga. I was diagnosed with osteosarcoma in my right femur in 2017. But as of now, I am 6 years NED, and I am now a rising sophomore studying biology at Creighton University.
Fantastic, Andrew. And then Dr. Azzam, we'll hand it over to you to go through your presentation.
Thank you so much, Christina. It's a pleasure to be here today. Let me go ahead and share my screen. I do want to mention it's very exciting to hear about the CureID. It's really relevant to what I'm going to be talking today. So it's good to know that there's that resource right now where we can use FDA-approved drugs in an off-label way and basically track that. Okay.
Yeah, capture that info. And again, everyone, please feel free if you have questions to just put them in the Q&A.
Perfect. So thank you so much for having me, Christina, and thank you for the kind introduction. You gave a really good background on my work. So I'm just going to start by saying that I'm very excited to be here and to tell you a little bit about the functional precision medicine work that I've been doing to guide individualized treatments for relapsed refractory pediatric cancer patients, including osteosarcoma patients, as well as adult cancers. So I hope by the end of my session, one second, sorry. So my disclosure is I'm a co-founder and scientific advisor of First Ascent Biomedical. So I'm hoping that by the end of the session that you would appreciate the foundational principles of functional precision medicine. And hopefully I will be able to convince you that functional drug testing today is not similar to chemosensitivity assays that you all may be familiar with, many years ago. It's the result of major technological improvement and expansion of FDA-approved drugs has really enabled the bridging of genomics with functional drug testing as clinical decision support tools to impact patient care. So precision medicine today commonly uses genomic profiling to identify actionable driver mutations in the tumor of the cancer patient, and that enables us to identify a matched drug or a matched treatment for each individual patient. Functional precision medicine is a relatively new field in oncology that integrates genomic profiling with ex vivo testing of hundreds of FDA-approved drugs directly on the patient's own living cancer cells to identify the effective treatment for each individual patient. So our work was recently featured on the cover of Nature Medicine in the April issue. But what I'm showing you today here is a gigantic maze. And this maze depicts the challenge that clinicians often face when selecting treatments for their patients whose cancers have returned or whose cancers are rare. And tools such as genomics, functional drug testing, and AI would provide an effective path forward for clinicians and their patients, as depicted here in the light. We conducted a clinical study a few years ago. We started this study in collaboration with Nicklaus Children's Hospital to determine if it would be feasible to implement functional drug testing and genomic profiling on relapsed refractory pediatric cancers, including both solid and blood cancers. And the question was, can we return results to a tumor board to direct the next line of therapy? So the answer to that question was yes, it is feasible. And we demonstrated that we could generate functional precision medicine data and return results to a tumor board within a clinically actionable timeframe. We then compared patients whose treatments were guided by functional precision medicine, which were 6 patients here, versus those whose treatments were based on physician choice. And I want to point out that since this was an observational study, it was up to the treating physician to decide if they would use the functional precision medicine data to guide the next line of therapy. So what did the workflow entail? We received, as I said, fresh tumor samples from relapsed refractory cancer patients, all types of cancers, both solid and liquid. And what you see here is that we derived short-term patient-derived cultures. Basically, they were a mix of free-floating and semi-adherent 3D cultures, along with individual adherent cells, as you can see here in the bright field images to the right. We tested a library of over 120 FDA-approved drugs at 10 different concentrations. The library included formulary drugs that are available at Nicklaus Children's Hospital. It included approved drugs that are in late-stage clinical trials for pediatric cancers. And also, we included some non-cancer drugs that have been investigated for potential repurposing as anti-cancer treatments. And we generated drug sensitivity scores for each drug. And what we did as quality control, we measured something called Z prime. It's just a statistic prime score that basically has to be greater than 0.5 to indicate that that the assay plates passed drug screening. And then, most importantly, as you can see here, we compared the IC50 of each drug to the Cmax of the drug. And what is a Cmax? This is the maximum concentration of the drug that can be achieved based on pharmacokinetic data. So drugs whose IC50 was less than the Cmax were used. And another important point, as you'll see here in this waterfall plot, is the higher the drug sensitivity score, the more effective the drug is. What we also did was and I will dwell into that later in my slides, is that we would use physician feedback and experience on selecting combinations of drugs based on their experience, based on known toxicity. And we would go back, if we had enough patient-derived material left, to test these combinations on the patient-derived cells to basically guide the best combination for the patient. In parallel, we validated the patient-derived cultures by different approaches. This included validating expression of specific pathological markers that are defined in pathology reports using immunofluorescence, as you can see here. We also validated specific genomic alterations using QRT-PCR. And finally, we used RNA sequencing and immune cell deconvolution approaches to show that the patient-derived cultures had over 90% tumor cells, as you can see here in gray. But what was surprising is that we also found a percentage of immune cells, stromal cells, and so it recapitulated the heterogeneity that is present in the tumor in which we derived these cultures. So we really believe that we've established culture systems that enables or that has a mixed cell population that closely resembles the multicellular composition that's present in tumors. Again, feel free to ask questions and interrupt if while I'm going through this. And this is another slide showing you that our cultures are a mix of 2D, 3D, as you can see here in the bright field images, And what we found was that there's this percentage of immune cells and stromal cells that's a mixed cell composition that's very similar to the original tumor that we derived, these patient-derived cultures. And remember, these are short-term patient-derived cultures. The main goal here is to use these cultures to test drugs and guide treatments, and it wasn't about, developing any long-term, culture systems from these. It was just to use them to find effective options for patients. So they're just short-term in culture.
Can I maybe just stop you there, Dr. Azzam, just
Yeah,
for
of course.
tutorial on the difference? Because I think some people are familiar with, different things like cell lines or organoids or, mouse models where you're injecting, patient tissue into the mouse and using that as a proxy or avatar to test drugs. And so can you just kind of give us a quick tutorial on how these patient-derived cultures kind of compare to those things?
Yes, I'm very familiar with these models, and these models are great long-term models that are that obviously again also recapitulate the tumor. But for what we found is that some of these models take some time to develop, and sometimes you have organoids, sometimes you have to wait 2 to 3 weeks to generate organoids. And for us, time was very critical because, as you know, we're dealing with relapsed refractory pediatric cancers, and they're known to be progressive in nature. And so we wanted to use models in the lab that will enable us to identify options quickly. So this is us doing this in a week. And that's why for us, we felt that these models were good enough for the purpose of using them to guide treatments. And we're showing that they're mixed cell composition, so they have all the different cell types that may be present in the tumor. So that's really what is different from all the other models out there. I think for us, time is very important, and that's why these short-term cultures were used in this case. And animal models take 3 months. So again, for us, time to give back results to the tumor board played a huge role here. So of the 24 tissue samples that we received, we returned drug testing on 21 samples and genomics data on 20. But what we found was, and here, sorry, I didn't mention the genomic panel we used was UCSF. It's a pathway-focused panel, UCSF 500. We didn't do whole exome or whole RNA transcriptomic. It was a focused panel. But what we found was that the turnaround time for drug sensitivity testing results, like I mentioned, was really higher than the turnaround time for the genomic results. As you can see here, the time for us to return drug sensitivity testing, median time was 10 days. And while genomics median time was around like a month or 3 to 4 weeks. So what happened in this case was the molecular tumor board basically discussed the results from the drug sensitivity testing first, and then we would basically modify the treatment if any genomic alteration was found later on. So it worked out that the patient was treated based on drug sensitivity testing, and then if any alterations were found, the treatment would be modified or added, the targeted drug would be added to the treatment. What was very interesting, and just this panel here in the graph in panel C, is that using genomics only, we were able to identify treatment recommendations for 5% of patients. But when we added drug sensitivity testing to genomics, we identified treatment recommendations for all the patients. And you'll see here that there was always treatment recommendations based on drug sensitivity testing, as you can see here. A drug sensitivity score of greater than 10 means that these drugs are more effective. Drug sensitivity scores between 0 and 10, they're partial activity. And then anything below 0 means these drugs are ineffective. And panels E and F just show how the number of assay plates that passed quality control based on Z prime and how many of those for both heme and solid cancer. So when we compared clinical outcomes of patients whose treatment were guided by functional precision medicine versus physician choice, what we found was that 83% of patients showed improvement. And by that, I mean achieved an objective response of partial response or higher as their best overall response. While only 13% of patients achieved an objective response or partial response or higher in the physician choice arm. And most importantly, as you can see here, progression-free survival in the FPM guided cohort was significantly longer than treatment of physician choice cohort. I also want to add here that you'll notice that many of these patients largely received readily accessible chemotherapy agents. And we have here an osteosarcoma patient, which I will focus a little bit and to show you more, but this is a treatment regimen for this patient, which is different than another osteosarcoma patient here. And these drugs are readily accessible.
I'm also curious, just looking at that list of these drugs, which, especially in the FPM guided, did they tend to be combinations that were already kind of in the standard arsenal of things that the clinicians would consider, like, well-known kind of combos for that?
Yes, that's a good
or
point.
were they really off the map? Were they things that were like, oh, we've never used this drug before in this disease?
We've had both, Christina.
Okay.
We've had drugs, and I'll show you, like idarubicin is not usually used to treat osteosarcoma. But then we've also had other combinations that are known to be given together. So the amazing thing about this is that we gave those, there was the ability to give different options for doctors, and based on many factors, as we're going to talk about, availability of the drugs, insurance, reimbursement, coverage, all that, doctors end up deciding which treatment they would give the patient. So as you know, since this is a small and a heterogeneous study, we used a commonly used metric in precision oncology studies, whereby patients serve as their own controls. So what we do here is that it's basically the ratio of progression-free survival of their current treatment versus previous. If it's greater than 1.3, that means it's a positive outcome. So what we found is that significantly more FPM-guided patients achieved a greater than 83%, achieved a PFS ratio of greater than 1.3 compared to the physician choice treated patients. And this is a commonly used metric in precision oncology studies. That ratio of 1.3, greater than 1.3 means it's a positive outcome. So as you see that, basically our study shows that patients whose treatments were guided by FPM had improved overall outcomes compared to those that were not, and compared to their own previous regimen. Since, the foundation is focused on osteosarcoma, I wanted to just show you one of the patients that we enrolled in our study. This patient had metastatic osteosarcoma. And you can see here that this is exactly, answering your question, Christina. So when we tested 103 drugs, you'll see the NCCN guidelines, right? These are the known guidelines for osteosarcoma. You have cisplatin, doxorubicin, or ifosfamide, etoposide. And we found those drugs to be effective. Here with, DSS scores not as high as idarubicin or Montelukast, which is an allergy medication, but they were still effective. And so in this case, if the doctor ends up deciding to use, doxorubicin and ifosfamide, it's still effective here. But the doctor in this case decided to give a combination of idarubicin with an allergy medication. And again, you'll see if you compare the outcome of that patient versus their previous regimen. So their previous regimen was ifosfamide and larotrectinib, and the outcome was stable disease. It was 17 weeks progression-free survival. while FPM guided, which was idarubicin, an allergy, and a Montelukast, had an outcome of complete response. And, the patient had 84 weeks of progression-free survival with no evidence of osteorecurrence. So that shows you how we, compared on how, the FPM guided gave a better outcome compared to physician choice or previous regimen. But also I wanted to highlight the cost of these drugs. I mean, again, idarubicin is an accessible, cheap drug. And if you compare just the cost of idarubicin is $100 a month compared to, $12,000 a month for fosfamide and larotrectinib. So that again highlights the utility or the ability of this test to provide maybe cheaper, readily accessible chemotherapy agents that are basically specific and would be effective for each patient.
And we did have a question from the audience.
Yes.
One audience member was wondering, how much tissue are you getting from pathology, and are you having to expand cells in order to have enough to test?
That's a very good question.
This person's mainly interested in osteosarcomas, which don't always grow well in vitro. Yeah,
so in this first study, we've used mostly surgical excised tumors, and so we would get, we could work with 0.3 grams of tissue, but now I'm going to show you later, we're starting to optimize this test even on fine needle biopsies and core biopsies. We can't test 120 drugs, but we still can test like 50 drugs or 50 single agents and combinations. And we've been able to give back data to the physician, even with even from biopsies that are fine needle and core biopsies. So again, going back to how long I need to expand these cells, the goal here is to be able to return results quickly to the doctor. So we try not to expand these cells for a long time. We really want to be able to give back data within a week or 10 days. So we are now advancing the workflow by integrating high throughput drug sensitivity testing of patient-derived cultures with genomic profiling and explainable AI. So what we're trying to do here, and the idea is that we want to start building these relationships between genomics or genes and alterations with functional ex vivo response. And think about it as we build this data set from each individual patient, where we have whole exome sequencing, RNA transcriptomics, response to hundreds and hundreds of FDA-approved drugs. All that data will enable us to use AI to start, hopefully in the future, predict combinations that would work for each individual patient. And also we can use AI to start identifying, biomarkers of drug response, and hopefully in the future, we'll really be able to start predicting treatment without even a biopsy, right? So there's huge potential of advancing personalized medicine when we're integrating all these different technologies and using AI. So we just started a new study. It's actually, we have an ongoing study that is the expansion of the study that we just published in Nature Medicine. The ClinicalTrials.gov number is here. It's on larger number of patients, and it is integrating multi-omic profiling with drug sensitivity testing to guide treatments for relapsed refractory pediatric cancers. Again, all types of cancers, both solid and blood. And I just wanted to give you an idea or a representation of how we're using AI to basically identify, drug response biomarkers specific to minority populations here, because, in Miami, the majority of our patients are minorities. So just to give you an example of how we're starting to use AI to discover biomarkers, for example, idarubicin, as you saw, was effective in osteosarcoma. And now idarubicin, idarubicin is a topoisomerase inhibitor. And if you look at the targets, the topoisomerases, they really did not do not predict response to idarubicin. But what we found was that there are other biomarkers here, like if we added BCL2, BCL2L13, or VEGF and HMGA1, they actually predicted response to idarubicin better than, or in a high correlative way. And if you merge all of them, you have an even better or a higher correlation of response to idarubicin. So this is just an indication of how we can use all this data to start identifying biomarkers with drugs specific to minority populations. And that's something that we're doing in this ongoing study. In this study, we are implementing the same approach, right? We get, receive fresh tumor samples from patients. But I want to highlight our first patient, who is a 5-year-old girl with metastatic osteosarcoma. She was 5 a year and a half ago, and she's still battling this cancer, and she's still fighting this disease, which is great news. But I wanted to show you how we're starting to optimize this workflow even more. So here in this case, we got her tumor from the primary lesion, and we tested, hundreds of drugs. And what we found was everolimus, which is an mTOR inhibitor, was effective. So the patient was started on everolimus. But if 2 months later, they resected the tumor from her lung. And we tested the lung tumor. And what we found was everolimus was ineffective on the lung tumor. And what happened? The patient did not respond to everolimus. So we ended up testing other combinations of drugs. And you'll see here to the right that like the combination of carfilzomib, cyclophosphamide, etoposide had a very high DSS score. And the patient was given that, and the patient responded. And so it was very interesting that, depending on the site, we find differential drug response in the primary versus the metastatic tumor. And just going over her, chart, you'll see, till today, so she was enrolled when she was 5 years old. Now she's six and over 6 years. But I wanted to show you how we're starting to actually receive more than one sample from the patient, how that is guiding her treatment. So, she had an amputation, like I said, primary lesion. That was the first sample we received. We thought she would respond to everolimus. She did not, because when we got the sample from her lung met, she did not respond, and everolimus was ineffective. But she responded to cyclophosphamide, etoposide, and carfilzomib. And then a year later, she had another resection on the lung, and that also showed a different combination of drugs. So that was switched. Now she's given, then she started to be on cyclophosphamide, topotecan, cabozantinib. And then now I think we got another biopsy of from the tibia because she had pain in her leg. But it was found to be it wasn't metastatic. That was great news. And so my point here is, if you look at her treatment was modified after every test that we did based on where we received the sample from. And she did have some delays because she had pleural effusion, but now she's on gemcitabine, docetaxel, and she's doing well. So really here, what we're starting to do now is we're starting to get additional samples from the same patient that will enable the physician to guide treatments and provide options over the 2 years.
Dr. Azzam, can you go back to the previous slide that had the, so over here under E, because there were a couple other combos that had a higher DSS score.
Yeah.
So yeah, why was that third combo?
Yeah, Christina. So I'll tell you this. So initially when we started the study, carfilzomib was very difficult the doctor had a lot of issues trying to get insurance to cover carfilzomib. But now, as we're getting more data, as we're using this data, the oncologist is starting to be successful in getting the insurance to cover for it. And so I think it all depends on how these drugs are given together and if they're published. For example, here, there's a published clinical trial where where carfilzomib is being given with cyclophosphamide and etoposide. So we're starting to notice that doctors are more comfortable using combinations that already are published or in clinical trials. And that's how they pick, the best option. So they're not always picking the most effective DSS score or the highest DSS score.
Gotcha. There are other practical considerations.
Many others. And sometimes it takes a long time for the insurance to approve the drug or the medication, and so they need to use other combinations. So yes, there's a lot of other factors playing a role here. But the good thing about this test is it provides a list of at least like 20 to 30 drugs and combinations. And again, those combinations are based on physician feedback. I think that has helped us a lot. Because physicians have the experience on using these combinations, and they've helped to eliminate a lot of drugs that are toxic. And I'll show you an example. Actually, it brings me to this slide. So I want to walk you through this because it's important. We're starting to learn a lot from how we look at these drug sensitivity scores. So let me start off by emphasizing the shaded drug here. So remember how I said that we only, when the IC50 is lower than the Cmax, that's when we use the drug. So here, trabectedin had a high DSS score, but if you look at the IC50, it is higher than the Cmax. So that's where we say the drug may not be effective. So that's number one. The other thing I wanted to point out is what's highlighted in red. So if you look at cisplatin on its own, right? Cisplatin on its own has a drug sensitivity score of 35.6. If you add cisplatin with vinorelbin, the score didn't really change much. So this says that adding another drug is not going to really do much. While if you add cisplatin with gemcitabine, you see the score is higher. So yes, here in this case, the doctor ends up saying, okay, cisplatin and gemcitabine has a higher DSS score, so I'm going to give it to them. But if you add if you add paclitaxel to cisplatin, as you can see here in the bottom, the score goes down. So we're starting to use these scores to really make decisions on, combinations. And sometimes drugs can be avoided some of these drugs are very toxic. So we're starting to get rid of many of these toxic drugs if the DSS scores don't change much. I wanted to show you here, we have another study that we're implementing on adult cancers, and this is a study open with Cleveland Clinic, Florida. But really what I wanted to show you is what I mentioned earlier, is that we're starting to, you're starting to use core needle biopsies and fine needle biopsies. So here you have this is how big the tumor is, but even this is a core needle biopsy, and this is a fine needle biopsy, and we're starting to, generate short-term patient-derived cultures, even from fine needle biopsies. And that's important because that will increase accessibility, and it will broaden the number, or increases the accessibility and broadens the number of patients that will be able to, use this test. Now, when the samples are smaller, what we're finding is very useful is physician feedback. And what do I mean by that? We go back to the physician, we say, okay, we have a small sample, we can test 50 single agents and combinations. What are you thinking? What are the options? What is the genomic results show? And we go back and we customize our library of drugs that we want to test based on all of that. And that has helped in, providing guidance to the physician to direct the physician in terms of what treatment recommendations would be best for the patient. And this is another clinical trial that's currently open. As you can see, this is, the number here of the ClinicalTrials.gov. And this is an example of, a metastatic urothelial carcinoma patient, right? It's a lung met, so it's a fine needle biopsy, and you'll see the cells here in this bright field image. But again, based on physician feedback, we couldn't test 100 drugs, but we tested these drugs, and you'll see that, in this case, these are the drugs that are most effective. These are the drugs that are partially effective, and then the ineffective drugs are here in the bottom. So it's really very helpful for us to work closely with physicians and understand like what are the drugs that they would like to test and help them make better informed decisions for their patients. So right now, we are working on establishing an academic CLIA lab for drug sensitivity testing, and that's going to be the first in Florida to provide drug sensitivity data to patients across age groups and cancer types. We received $2 million for this, and really the goal here is to be able to launch large-scale, prospective, multi-center, randomized clinical trials to better assess the clinical utility of functional precision approaches in the treatment of relapsed refractory cancers. Developing a CLIA-certified test for this is resource intensive. It's what we're doing now is taking that research assay to become CLIA-certified. So it enables us to make it more of a diagnostic test, and in that we have to show that our test is reproducible, accurate. There's so many quality measures that we have to prove for us to for this test to be CLIA certified. And it only can be operated by Florida licensed personnel. So it's been a journey. It's a huge undertaking, but hopefully we're very close to getting this test CLIA certified for both solid and liquid cancers, and be able to test hundreds of FDA-approved drugs. So we're very excited about that. But clearly, the goal is to get FDA approval, right? So CLIA will provide that foundation to move this to FDA approval and hopefully insurance reimbursement as well. What are the challenges? I just wanted to mention a few of the challenges that we experience in our clinical studies. One, and we mentioned that in our paper, which is physician hesitancy. So obviously, we need to increase the physician awareness, using new approaches in oncology and new types of data that will help influence clinical decision making. I think that out of I would say 20 patients, only 6 were guided by FPM, and that's because physicians are hesitant to use this data to inform the next line of therapy. And I believe even genomics precision medicine has the same challenges. So we want to be able to increase awareness among physicians or the medical community to collaborate with FPM researchers like myself and really try to use these new tools and technologies to better inform their treatment decisions for their patients. And as we get this test CLIA certified, we'll be able to launch large-scale prospective studies, randomized studies to really assess the clinical utility of functional precision medicine approaches, as I mentioned. Now we're working on relapsed refractory cancers, but I'm hoping that we will start to launch prospective studies on newly diagnosed patients. And I'm really excited because I want to be able to start a study on newly diagnosed osteosarcoma patients, because I believe that there's a lot of more options that we can provide for osteosarcoma patients upfront. So that's really my goal. Out of all the types of cancers, I'm going to start off with osteosarcoma. Again, the other challenge that we have is access to off-label use of drugs, as I mentioned. And your questions, Christina, like why are physicians not using the top most effective drugs? It's because these are off-label, and trying to get access to these off-label drugs, trying to get them covered by insurance, all those financial restrictions play a role. And then the most important one, I believe, is that we need to start, generating or having viable biobanks and tissue repositories, because right now, and I believe that we'll learn more from living cancer cells than fixed dead cells. So that's another important aspect that we should all work on to increase the number of viable biobanks. All right, so I just want to end by thanking my team at FIU and my dean and all my collaborators at the different hospitals, also the patients and their families, and all the support that I've received from the different funding agencies.
All right, we did have another question from the audience. Someone was wondering, is the screening only available to patients to the clinical trial now? And when there were hits in the screen, have you gone back and rationalized the result via genomics?
Yes, that's a very good question. So right now, the screens are only available through our 2 clinical studies here in Florida. Hopefully, when we're CLIA certified, we can start providing this test outside of these clinical studies. So that's really my goal right now. To answer the other question, did we go back and we looked at the genomics all the time? I mean, having both side by side, the genomics data and the drug sensitivity data has really helped a lot. What we found is exceptional responders are those that we've used data from both the genomics and the drug testing and the drug sensitivity testing. I'll give you an example. We had a patient with relapsed leukemia, and that patient had a FLT3 mutation. And what we did was we knew that the patient had a FLT3 mutation. He had gone through chemotherapy, but also had gotten sorafenib, which is a FLT3 inhibitor. But the patient relapsed. And so when the patient was enrolled into our study, we tested all the FLT3 inhibitors that are out there. And we selected the FLT3 inhibitor that was the most effective using the drug sensitivity testing. So both the genomics and the drug sensitivity testing guided, the matched treatment for that patient. And then we also found chemotherapy drugs that would be effective for that patient. And the patient went, really the patient responded to this FPM guided treatment in a month and underwent another bone marrow transplant. The patient's been in remission for over 2 years. So the exceptional responders are when we use both. That's at least from my experience.
And then we had another question. What size TC plate are you using for your drug studies? And then what endpoint are you using? And then DAPI, direct cell counts, or some type of reporter agent?
All right, let me start with the first one. So what type of flask? Depending on the size of the tumor, we modify the flask. So if it's a fine needle biopsy, we're using maybe a 24-well or a 6-well plate. But if it's a bigger, depending on the size of the tumor. So that's the answer to the first question. What was the second one? Sorry.
Yeah. Oh.
Okay.
Oh, yeah. What
second one is
are you using either DAPI, direct cell counts, or some type of reporter agent?
No, we are using, so we're measuring ATP. It's just a cell viability right now. So we're looking at its ATP bioluminescence.
And then I did have a question. You talked a little bit about how physicians are sometimes hesitant to kind of collaborate with you guys. Do you think a lot of that is because it's kind of newer and they just don't trust it as much? Or do you think it is the awareness you were talking about where they actually just don't know?
I would say both. So, and the reason I say that is because chemosensitivity assays are not new. A lot of physicians, maybe when they were residents, were doing these chemosensitivity assays in the lab, and they didn't work because they were very primitive back then, right? And so what we want to tell physicians is that we've really advanced a lot in how we grow tumor cells in the lab. And we've advanced in the technologies that we use to dispense drugs, that we can now dispense nanoliters of drugs, really, really small volumes through sound and quickly. So we want physicians to look at the data today and reevaluate and look at all the prospective data that we have right now. Obviously, we need more prospective data and more clinical studies, but I encourage them to just look at the data today and before being hesitant to using these tools, and collaborate with FPM researcher and try to start using it, because based on my experience, when in my studies, physicians, when they're hesitant and they start using this tool and they're starting looking at the data, they really feel that the data is very useful to give them a better idea of what would work next, especially when patients don't have any more options or they've exhausted standard of care.
All right, and this next one was a two-parter. So someone was wondering, firstly, how often did you find effective drugs in subsequent testing that were not effective in the primary tumor? And then secondly, why don't you advocate for larger biopsies to maximize the number of drugs you can test?
So I'm going to start with the second question. I would always advocate for a larger biopsy, because the larger the tumor, the more drugs we can test. So, but obviously sometimes we're limited. Sometimes pathology needs to take, it's always a fight between pathology and taking a sample to for testing, for drug testing. So the bigger, the better. But, we found that even with biopsies, we're still able to give good information and data back to physicians. The first question, could you repeat the first question?
No, no worries, no worries. So the question was, how often did you find effective drugs in subsequent testing that were not effective in the primary tumor?
Yes, we have found instances where the drug is effective in the primary tumor, and then the patient responds, and when the tumor returns, the tumor now has a completely different biology, and that's where sometimes we find differential drug response in a subsequent tumor, and now I'm showing you that the primary is different than the metastatic site. Not always. Sometimes what we're finding is some drugs are common in the primary versus the metastatic site, and I believe those are the drugs that should be used, right? If you have a drug that's targeting both primary and met, that's the drug that should be used for treatment.
There was a clarification to that question. The same person said, the question is if new sensitivity evolves.
Yeah, let me see. Yeah, I mean, if the new sensitivity from the same culture, no, not from the same culture. New sensitivity evolves from another sample from the same patient, but not from the same culture so far. We've done a lot of those studies where, we don't grow these cultures over a long period of time, but we've done some studies to validate, and so far we're seeing very, very good response, a good correlation with outcomes.
And then I guess another add-on, one question was later secondary metastases.
Yeah, I mean, exactly. That's what we show in in that patient that I showed you. We received 4 samples from the same patient, and it was, different metastatic sites. So we're starting to see these differential response to drugs, and we're starting to pick drugs that are common in the secondary mets versus the first.
On the question of a couple things on I think someone had asked earlier about participating in the trial, and can someone participate remotely, or do they have to be a patient of record at the institutions that the trials are at, or could they send their tissue from an
Not yet. So they are going to have to be, the way our clinical trial is approved is they have to be a patient at Nicklaus Children's Hospital or Cleveland Clinic. If they contact the doctors at Nicklaus, we're trying to find ways to collaborate in a way that they can send a sample. But when we're CLIA certified, that's when we'll be able to expand and really try to get samples from sites that are not at Nicklaus or Cleveland Clinic. We'll expand our sites. I'm looking forward to that.
Yeah. And I think the paper that you published recently in Nature Medicine, and I did put that link if anyone's looking for it in the chat, is definitely a first step, I think, to getting oncologists more comfortable with the idea, right? Because they're always just looking for evidence-based, like, is this really going to make a difference? So I think that's a really important step. And I love that you are looking at potentially using this for osteo for earlier in the process. And I want to just throw out like a couple of scenarios. I mean, today, I think a common question that happens is when an osteosarcoma patient has a relapse, or they've gone through already 2 or 3 different types of cytotoxic chemotherapy, or they're looking for like a maintenance drug or TKI. Often it's like, which one do we use? Because there's probably about a few. There's a few like cabozantinib, regorafenib, sorafenib, pazopanib, older one. But I think now it's really based on the physician's experience with that drug and how tolerable it's been for other patients. versus really knowing, like, is one going to be different from the other? Granted, they are like multi-TKIs, so
Correct.
similar mechanism of action, but this, for example, could be like a quick way to maybe just test that panel of TKIs, right? And just see which seems to perform better. I mean, barring having any other data, right? This would be kind of a quick litmus test.
That's exactly right, Christina. That's where I emphasize that we could always look at the genomics data. We have, like you said, we have a mutation, a RAS mutation, and then we go and test all the drugs that, are PI3K inhibitors that are out there. And it's really been very helpful to do both and integrate both. And the, physician will look at the data and say, okay, maybe this makes sense. This is the most effective. Let me start off with this inhibitor. And it's helped a lot in guiding the physician on next step. Especially like you said, like, okay, well, how do we know which one is going to be best? Obviously, their experience and evidence-based and everything. But when you have more than one TKI, how would you know which one is the best? And that's where drug sensitivity testing data is very, very helpful.
And then the other kind of use case scenario, thinking about the planned trial that you'd like to do for osteo, to kind of think about this early in the process, is like, because it is so fast, you think you could get to the point, because you can get samples, enough sample off a core biopsy to basically use the biopsy sample to inform first-line treatment.
Yes.
Or even at this point, if it's not going to change whether or not someone's going to use MAP, at least it would be interesting to study how that initial test compares to necrosis or disease progression, 100%. And see if it is and then go to the next step of, maybe it could help you inform whether or not you start with MAP or IE or gemcitabine.
Inform the different treatments that, I mean, even as you saw the combinations, right? Like, which combinations are best? I mean, is it ifosfamide with, etoposide, or ifosfamide alone is active? And can we get rid of, etoposide? That just, those are the drug sensitivity scores are starting to be very helpful in making those types of decisions. And as you know, these drugs are very toxic. And so trying to eliminate one of those drugs and seeing, two drugs are as effective as 3 drugs. I mean, that's incredible when you can get rid of the third drug that's toxic and you can still have a good effect on killing the cancer. I think that's the goal, and that's how I believe functional precision medicine will help a lot in newly diagnosed as well.
Fantastic. Thank you, everyone, for all the questions. And thank you, Dr. Azzam, for really engaging discussion. This all sounds really fantastic. I mean, and it's also just hopeful to hear how technology has advanced such that you can do this type of testing in kind of a quick turnaround, just because the timing is so important. I mean, I kind of remember, back in the day thinking that it was like genomic, when we were all talking about genomic profiling, sequencing, and how that could help drive and inform functional precision medicine, like kind of again, combining that information of like looking at what mutations you had, and then helping you choose then which drugs to test based on that. Though interestingly, because the FPM is faster, at least at diagnosis, that's actually more, you're starting with that. I think it's pretty interesting.
Yeah. And I remember, now, the cost of genomics went down a lot, right? And I believe that also the cost of drug testing will go down eventually in a few years. So it'll be very, cost effective to do both and use that hopefully to impact patient care.
Well, thank you so much for joining us today and for making it better for pediatric sarcoma patients. More information on this and all OsteoBites can be found on our website at mibagents.org, on the MIB Agents YouTube channel, and at your favorite podcast place. And next week on August 15th, we're dropping a new episode of our Osteo AYA podcast. Our host, Mia Sandino, she's going to be joined by a couple other osteo warriors to discuss the very unsettling transition from treatment to monitoring in the August episode titled Clear Scans, So Now What? So you can find that episode on our YouTube channel and at your favorite podcast place. And I'll also put a link in the chat to where you can look for that. And then we're going to be back with OsteoBites the following week on August 22nd. We're going to be talking to Dr. Brigitte Persson, a professor of soft tissue surgery in the Department of Clinical Studies at the Ontario Veterinary College at the University of Guelph. and she will discuss her work on magnetic resonance-guided high-intensity focused ultrasound for palliation of canine appendicular osteosarcoma. You can find our OsteoBites lineup for the next few months on our website, and if you have any ideas for future topics you'd like to hear about, please feel free to email us at events@mibagents.org. Thank you again, Dr. Azzam and Andrea, for spending an hour with us today. And thanks to all of you for taking time out of your busy days to be here with us. We hope to see you back here on August 22nd when we talk to Dr. Brisson. Thanks, everyone. Thanks so much, Dr. Azzam. Thanks, Andrew.
Thank you so much for having me. It was great.